So even before we start, I think we can ask Pradeep a couple of, because what basically was he's trying to deal with is a case of normal tension glaucoma. Right, Pradeep?
Yeah.
Intraocular pressure is low teens. So many of us are now facing this dilemma that should we treat it or should we not treat it? What is to be done about it? So we'll have to see what he has to say.
Good morning, friends. Thank you, Dr. Harsh, for giving me this opportunity. So Dr. Harsh has given me the topic. The IOP is in low teen, but disc and fields have glaucomatous damage. Treat or not? So obviously, if you say that what he was telling, that it's a normal tension glaucoma, so if you say that it's a normal tension glaucoma, then obviously it's a pathology, and any pathology has to be treated. But why he has asked me to tell about that not to treat? Because there might be some other condition which might mimic like a normal tension glaucoma, but may not be a normal tension glaucoma, and there you may not have to treat these patients. ये फॉरवर्ड नहीं हो रही है भाई स्लाइड्स? Okay. So the situation he has given to me is that the disc is a glaucomatous. हाँ नहीं वो जा नहीं रहा था उसमें. ओके ठीक है मैं पॉइंटर तो बना लूँगा मैं. ठीक है चल रहा है ना? हाँ ठीक है अब चल रहा है. Okay, so it's working all right now, it seems. Okay, so the situation is this. You can see that the disc is glaucomatous, and there is a splinter hemorrhage, there is a RNFL defect, and there is a visual field defect. So obviously, if you have that kind of a patient, then you tend to treat. But sometime you don't have to treat. So let us think that what all situation could lead to this kind of a condition where disc looks like a glaucomatous. There is a correlating visual field changes. Obviously, as Dr. Harsh said, that first is the normal tension glaucoma. Second, it could be an intermittent angle closure. You know, when the patient comes to you with a normal pressure, but repeatedly the pressure goes up because of the angle closure disease. But this intermittent angle closure disease might have damaged the disc. The third is patient may have a very thin cornea and patient comes to you, but erroneously you record a very low intraocular pressure. The fourth is the fluctuation. The patient, when he visited to you in the office, during the office hours IOP is low, that is because of the fluctuation. You are recording the trough IOP, that is a possibility. But there are some situations which are also very important, like a steroid-induced glaucoma. The child was treated at the young age with a steroid for vernal keratoconjunctivitis or for any other disease which require use of steroid. It may be use or abuse. And because of that, the patient had high pressure, damaged disc cupping, subsequently steroid was discontinued for a long time, and patient visits to you after several years and you record the pressure is normal, but there is a disc damage, and when you do the visual field, then visual field also shows the glaucomatous defect. It's not a very rare condition. Quite often we face this. There is an old trauma. The pressure is normal. You do the gonioscopy, there is a small angle recession, but patient might have had a very high intraocular pressure for a prolonged duration because of the hyphema or trabeculitis induced because of trauma, and then the pressure has become normal, but it has, at that time, it has caused the disc damage. Then the PDAs, the pigmentary dispersion syndrome. So quite often, it is quite possible that PDS has caused high intraocular pressure, but over a period of time, all of us knows that it burnt out and the pressure becomes normal. And once the pressure becomes normal, then obviously the disc damage and the visual field damage remains. Recurrent uveitis, particularly the Fuchs and the PS, the Portner-Schwarzman syndrome, where the patient have a recurrent episode of the uveitis related to the high intraocular pressure, and this repeated episode of the uveitis may cause a high intraocular pressure and may cause a disc damage and the visual field damage. And then there are certain neurological conditions and the vascular condition. In the vascular condition, particularly a very low blood pressure that leads to a poor diastolic perfusion pressure to the optic nerve and the retina. There could be other condition as well. The congenital optic disc anomalies, the retinal pathologies, and most important is the senile sclerotic disc. You must learn to differentiate between the normal tension glaucoma and the senile sclerotic disc. Senile sclerotic disc looks pretty similar to normal tension glaucoma, and on visual field you may get generalized reduction in the sensitivity, but that patient does not have a glaucoma, and that 80-year-old gentleman should not be pumped with lots of anti-glaucoma medication. So this is a congenital anomaly. It's a classical coloboma with related visual field defect. Sometimes the ophthalmologist may get confused with glaucoma, but that is not. And I have seen number of patients have undergone trabeculectomy as well. This is a retinal condition where, retinitis pigmentosa, BRVO, CRVO, they may cause a kind of a glaucomatous defect. And if there is a slight enlarged cupping, then you may confuse. And if you have not seen dilated fundus, then obviously your diagnosis may be wrong. AION, you have to differentiate whether it's a disc pellar or it's a cupping. And obviously the visual field defect also says that it's a neurological defect where it respect the horizontal or the vertical meridians. This is another field where the patient had a pituitary adenoma and there was a bitemporal defect. There is another kind of a disc anomaly. You can see that it's a tilted disc with inferior corner, and if you see very carefully, then you may feel that the inferior rim is lost and the pressure is normal. Then what would you do? Perimetry, yes, there is a related superior arcuate scotoma in both the eyes, and if you do the OCT, there is an inferior temporal RNFL defect in both the eyes. But believe me, this patient was followed up for more than 10 years and it's stable. There is no progression. So obviously it was a congenital defect. So these patients either would not require any treatment, just a follow-up, or require the treatment of the condition which they have. If your patient has a normal tension glaucoma, then what would you do? The normal tension glaucoma disease study suggests that the pressure has to go down by around 30% from the baseline. That is the objective. If your patient has a pressure of 12 millimeter of mercury, then the target should be 9. But the good thing with the normal tension glaucoma is that these patients are very slow progressor. That is one important thing. So obviously, you have lots of breathing space, and there are other conditions as well which you have to keep in mind if the patient has a low tension or normal tension glaucoma. You always look into whether the patient has a sleep apnea or not, whether patient has a thin cornea that we have already discussed. Patients usually who have a migraine, Raynaud's phenomena, low nocturnal blood pressure, as we have discussed, they all have a tendency of development of a normal tension glaucoma. And the new concept is that whenever there is a low CFS, then these patients also tend to develop the normal tension glaucoma. People have suggested giving extra salt if the patient has a low BP. I don't have any experience, I have not practiced it, but for low CFS pressure, I do not know what treatment has to be given for these patients. So there are some other conditions, as we have discussed, that sometimes there is a physiological cupping, and it is erroneously considered as a normal tension glaucoma. But as we have seen that you should do the vertical follow-up, and if there is no further defect or there is normal visual field and OCT, then you don't have to treat the patient. And if there is a coloboma and obviously there is optic nerve pit, then these patients would not require any treatment, just observation. I was discussing about the burnt out PDS. So how would you recognize the burnt out PDS? Usually in the PDS, the excessive pigmentation will be at the inferior quadrant. But when it is burnt out, all the inferior quadrant pigmentation or the pigmentation at the inferior angle is engulfed by the phagocytes, and only the superior pigmentation is more prominently visible. So that is the burnt out glaucoma, and you have to look for the angle recession as well. This is a quite clearly visible is a PDS. So these are all the conditions which you should look for, and don't treat those conditions where the other form of treatment or other investigations are required. So first investigate and then initiate the treatment as per the need. So normal tension glaucoma, you have to look into whether the patient really has a normal tension glaucoma or it is associated with some other condition, and because of that the patient has developed it. If it is a true normal tension glaucoma, then the prostaglandin analog is the first choice of drug. The alpha-2 agonist and the carbonic anhydrase inhibitor, yes, suggested to be a vasoprotector and a neuroprotector, but we do not have a good scientific evidence where we can use this drug to primarily treat the normal tension glaucoma. So even today, for me, the best drug of choice is the prostaglandin analog, and if required, then I would like to add the alpha-2 agonist or the carbonic anhydrase inhibitor. And as far as the follow-up is concerned, the follow-up is same as like a primary open-angle glaucoma.
So
Pradeep, thank you very much for your patience.
Not thank you, you still stay here. Because you have to clarify for us कि भाई एक patient आया and he has got, like you very rightly, Dr. Pradeep pointed out, all those cases of burnt out glaucoma. अब मुझे ये बताओ उसका advance, there is an advanced damage, okay? Now, so now how do I at that point of time decide, because I cannot be 100% sure whether it was a burnt out case or it is not a burnt out case. So how do I decide whether to treat it or leave it? Because since it is an advanced damage, am I okay in leaving it, let us say at 14 pressure, and following it up to see how the fields are going, or would you rather take a risk and treat it?
You know, it's always a big dilemma whether to treat these patients or not to treat this patient. But simply, most of the glaucoma experts who have seen the patients going blind, if you see a patient only a temporal island of visual field is left, then obviously you would like to treat this patient, because there is nothing harm in putting the patient on a treatment and do the follow-up. Patient also would not mind putting up the one drop every day, that is a prostaglandin analog, and over a period of time, if you feel that the patient is progressing, then obviously you must consider aggressive lowering of IOP even if the pressure is in single digit, and then the trabeculectomy is indicated for these patients for aggressive lowering of IOP. But advanced defect with the normal pressure, and you feel that patient may not have a normal tension glaucoma, it might be related to some other condition, but still don't take a chance and treat the patient. Give a benefit of doubt to the patient.
Thank you, Pradeep. I think that was a very important message. This crux of this talk was, यही हम लोग message आप लोगों को देना चाहते थे कि whether actually should we treat these people. The question is, we don't have a choice. You know, we may, if there was a choice, if the defect was not that advanced, we may just hold back and see whether the fields are advancing and then decide that. But like rightly he pointed out that giving one drop may not be bad enough, and the patient would definitely be scared, and if he goes somewhere else, somebody else will start medication, definitely. So it is better that you keep things under control. And so if there's an advanced damage, you have ruled out the first thing, like he rightly pointed out, all those cases you have to rule out what it is. If it is something else, if it is something specific you can find out, fair enough. If you cannot find out anything specific, it is probably safer to treat until you are sure which way you are headed. Thank you so much.